So this is about Department of Health, and they're talking about what's going to happen next. Fee for value is now very well situated within Medicare. 48% of Medicare patients are being seen on a fee for value basis, and their goal is to get it to 100% by 2030. That's not going to happen, but they're still making huge progress. In fact, far more progress than they're making in private insurance.
For the latest in health-related information and ways to save your life, check out the newsletter.
And that's really what this article was about. The article was what's going to happen on the private insurance space. Value-based healthcare is a healthcare delivery model in which providers, including hospitals and physicians, are paid based on health outcomes, not based on how many prescriptions. Under value-based care agreements, providers are rewarded for helping patients improve their health, reduce the effects and incidence of chronic disease, and live healthier lives. In other words, there's significant time there for patient engagement and education and looking at evidence. Now, they looked at a couple of possible scenarios in this PTAC public health meeting regarding the total cost of care and the impact of how care is managed in the private healthcare insurance industry. One was an industry-wide reimbursement standard change to fee for value, and the other was public and private payers split on risk. Actually, you have very little private payers at this point getting involved in risk. What you are likely to see, and what you're starting to see already, is both of them are split, both public as well as private payers. The public is way ahead, Medicare by far being the leader in this space. Other groups are getting there, and private groups are the laggard. Value-based payment models in the commercial sector, there's a roadmap to population-based risk. There's upfront investment and focused on the partner's needs, and employers have to agree to trade-offs. Employers are not there yet, and until employers begin to understand it, the insurance companies are going to have a hard time understanding it. There are special challenges within this commercial group. Again, it tends to be driven more by employers. With commercial groups, they're looking at younger patients. Medicare is by definition 65 and older, except for certain disabilities. There's a different set of issues, one of them being the risk of overutilization. For example, procedure after procedure because the patient just wanted a better and better outcome or thought they were going to get a better outcome. Joint replacements, low back surgery, those kind of things tend to get done over and over in that environment. So Medicare, on the other hand, is aiming to focus on chronic disease management, prevention, and a slightly different set of goals. So here's a couple of the trade-off options that we're looking at. The providers competing to find high-cost areas and address partnerships. So again, things like joint replacements. And you'll see things like medical tourism, where people are saying, look, we're going to have an episode of care, and if you can get a joint replacement done with this level of quality and at this cost, then we're going to start moving our patients to that group, even if we have to pay travel expenses to get them there. A more holistic approach with Medicare is looking at the raft of prevention and patient engagement lifestyle components in order to decrease the chronic diseases that are happening in that population. Again, you're going to end up seeing mixes of both approaches because they deal with both populations. Are you not going to see Medicare going into or fee for value going into the employer market? No, you will see that.